In this video lecture, we're going to finish off Chapter 5, the skeletal system, and what we're going to go over today are bone fractures, bone markings, and the bones itself. And because there are lots of bones we're going to go over, I compiled a list of all the bones you're going to need to know for exam number 2. You can find this under resources in La Lima. Now, the way this is going to work for exam number 2 is that they'll have fill in the blank, and you're going to have identification. For the fill in the blank, because spelling will count, the very first 3 spelling errors. So the first 3 spelling errors, those are going to be forgiven. Anything over that, so any error over 3, this is going to be 0.25 off. And I'll write that again on your list of bones that you need to identify. How do you practice for this, and how do you practice identification? You can go to Practice Anatomy Lab, and you can access this one of 2 ways. You can go through this one website, or you can download the app on iTunes following this website right over here. And really what this does is it provides you a way to look at the different bones, practice your pronunciation. You can click on a bone, it'll say it for you. You can also hide the labels and then practice identifying it that way as well. And so I can't access this on my Mac. It's pretty difficult for me, but not to say that it has not been accessed on a Mac before. I have students who were able to access it on Macs. I just haven't changed my settings yet. So unfortunately, I can't show you what this looks like. But once you get to this page, you're going to see a bunch of tabs on the side bar that's going to look like this, and it's going to have different systems. So skeletal, muscular, integumentary, fetal pig dissection. And you're going to click on the one for skeletal system. And you can access the axial and appendicular regions, and that's how you can get to all the bones that you're going to need to know. Okay, so if you have any problems or questions on that, let me know. This is a free resource that I found online, and I think you can also purchase it if you want. However, if you are having trouble, we can try to find other ways of you getting this resource. Alright, so let's go over bone fractures, which is the first part of lecture today. And we're kind of taking a little step back. And so last time we ended with how do you repair different types of fractures. And what are the 2 ways and 2 methods of repairing the fracture, the 2 steps? Good. First you have reduction, and then you have immobilization. Reduction meaning that you want to put the ends of the bones together. And then finally mobilization, holding all those bones in place to allow repair to occur. So you have that hematoma formation, fibrocartilage formation, spongy bone, and you also can digest that away and form that medullary cavity. Now let's go over these different types of bone fractures. On your exam, you should know the fracture type, the different types of description, and what population is common in. So it's an older population or is it a younger population? This will most likely be a multiple choice question on an exam. So let's get started with the first one being comminuted fracture. And this is common in older people, and why is that? Because their bones are more brittle. And so if that's the case, when a fracture occurs, these bones are going to break into very small fragments. Second type of fracture we have is compression fracture, also common in older people, especially those suffering from osteoporosis. This is what we saw in the last chapter. If we're looking at that vertebral spinal column, especially somebody who has osteoporosis, very porous bones over here. If they fall or if they carry something heavy, they can cause these bones to fall upon each other and compress, and then have that humpback appearance. And so leaving that bone is crushed. Third type of bone fracture we have is depressed. This is common in a skull, so those flat bones. And when the bone is pressed inwards, so here's an example. Also here, this bone is pressed inwards. Impacted bone, this occurs when someone tries to catch or break a fall by extending their arms out. Here is an example. Somebody extended their arm out, and then their humerus and their scapula came into close contact with each other and then allowed their bone to break. 5, we have spiral fracture. This is common in sports, especially people who are very aggressive, putting a lot of pressure in one direction and forcing your pressure in another direction, giving rise to 2 separate bones. And then finally we have green stick fracture, and this is very common in children because their bones are more flexible. And so anytime if you see this tree that's not very mature yet, you try breaking it in half, you'll notice that the ends will start coming apart. So part of it that when you bend it this way, this side is still going to be completely nice and straight, while these ends are going to break. And that's really what a green stick fracture is. So it's an incomplete break. Now let's go over bone markings. Bone markings, what these are surface features of bones, and there's two different ways we can identify these. They can be sites of attachments for muscles, tendons, and ligaments. So sites of attachments for muscles, tendons, and ligaments. Or they can be passages or passageways for nerves and blood vessels. And there's different categories that we give to these different bone markings. They can be projections or processes, in which case they're going to grow out from the bone surface. They often begin with the letter T, so we'll see tuberosity, trochanter, or they can be depressions or cavities, in which case they're considered indentations. And they often begin with the letter F. And so we'll see facets as an example, among many others. And so for this bone markings on exam number 2, I want you to know the name of the bone marking and the description. You do not need to know the illustration for this. So starting off with the projections that are where muscles and ligaments attach to. First one we have is tuberosity, and here's an example of a tuberosity, large rounded projection. Crest, this is a narrow ridge of bone. Iliac crest is the most common one, comprising and giving rise to our part of our pelvic bone. Trochanter, this is large, blunt, irregularly shaped processes, and here's one. The only example being the one on the femur. Line being a narrow ridge of bone. So here's that intertrochanteric line, inter being between, trochanter, so those two regions. Tubercle, small rounded projection or process, and so tubercle we have is right over there. Epicondyle, raised or above a condyle, and so medial condyle is here as an example. Spine, slender, pointed projection. And then we have a process is this prominence. So all of these are large extensions. Now looking at projections that form joints, meaning where bones and bones come together. Here we have a head, and heads are often extensions of necks. So here's our necks. Facets, bones and bones come together here. So here's a facet, flat surface. Articular, that's where they actually come together. Articulate, when things articulate, they touch, come together. Condyle, articular projection. So here's a condyle coming to contact with another bone. Ramus is an arm-like bar. So this region right over here. Next category of bone markings we have are depressions and openings. So the first one we have is a groove. Here's an example of a groove. It's kind of like a furrow, so it's going inside. Fissure, narrow slit or opening. Here is an orbital fissure. Foramen is a hole. Most important one that's most obvious, not necessarily most important, but most obvious is the foramen magnum, being that one hole at the base of our skull where the spinal cord goes through. So it's a round or oval opening through a bone. We have a notch, indentation of a structure. So here's a notch. Oops, so that's supposed to be number 16, 17, 18, and 19. We have meatus. This one is most likely the going to be leading for hearing. So we have external and internal acoustic meatus. Sinus cavities. Here we have paranasal sinuses, residence and speech. And then finally we have fossas. Here we have this basin-like depression. Okay, so also being an area of articulation. So fossa. Alright, that's all we need to know for our bone markings. Now we're going to go over the different types of bone identification. And so we're going to break this down looking at the two major divisions, which were what again? So everything in blue is the axial skeleton. And then everything that's extended are and comprises the appendicular skeleton. So now let's go look at all the different types of bones that comprise these. So we're going to start off with the axial skeleton. What's comprised in this? We have the skull, we have the hyoid bone, auditory ossicles, those are found here within our skull, vertebral column, and the thorax, which comprises the sternum and the ribs. So we can break this down to three major regions, being the skull, vertebral column, and the bony thorax. And so bony thorax is this right over here, and this is all underneath the skull, and then here is that vertebral column. Okay. And so here we have an anterior view of the different regions we're going to cover, and then of course our posterior view. Now let's go over the skull. And so if we look at the skull, there's actually two different types of bones that we have. We have cranium bones or cranial bones. Okay, so we're down over here. I know I wanted you guys to see the bones more so than my notes. So here we have cranial bones, and we have facial bones. Okay, so let's break down these two different types of bones. And so cranial bones, what these do, so we can say cranium or cranial, these protect the brain. And then facial bones allow for movement of the face. As they serve as attachment sites for all those muscles. And so let's first go over what are the bones that comprise the cranium. The first thing that we have is the frontal bone. So right over here, the frontal bone. This acts as the forehead or superior surface. Also superior surface of the orbit or the eye. And so we have one of these. Second thing, we have our parietal bones, and we have two parietal bones, and these form the sides and also the roof of the cranium. Okay, so frontal is the forehead. It's the superior region of the cranium. Another area that we have, another bone we have is the temporal bone, and we have two of these as well. And this also helps serve as the sides and base of our cranium. We have one occipital bone over here, and this serves as also the base. And then we have the sphenoid bone. Kind of sounds funny, right? So sphenoid bone is over here, and this is actually a butterfly-shaped bone, and there's only one of them. Kind of looks like there's two because it seems like there's one on the opposite side, but there's only one. And it's a bridge between both the cranial and facial bones. And then finally, we have the ethmoid bone, and this is the nasal septum. but it also lies more anterior to our sphenoid bone and is still part of our cranium. Okay, so all in all, ethmoid, we only have one of those. Okay, so everything that you see here in green, everything in green, this comprises our cranium. Okay. Now let's look at the facial bones, and I'm just going to clean this off really quick. And facial bones we're going to have here in blue. Now one important thing before I go into that is that how do we join these different bones together? It kind of looks like the skull is one whole bone, but in actuality it's composed of these many bones, and they're all joined by sutures. And in our entire skull, the only freely movable joint that we have is going to be the mandible. So it's attached by a freely movable joint. Okay, so let's go over these facial bones. The first one we have is the mandible. This is the only freely movable one. Another one we have is the maxilla. And maxilla is actually comprised of two bones, even though it looks like one because we're looking at it halfway. Another bone we have is the zygomatic bone. This is our cheekbone, and there's also two of those. Okay, so we went over zygomatic, mandible. What else do we have? Maxilla. We have the lacrimal bone. Lacrimal bone, also the sides of our nose, our nasal cavity. There's two of those. Nasal bone, also two of those. Gives rise to the part of the shape of the basis of our nose shape. Although most of it is actually going to be considered cartilage. And then now let's look at the other one. So we have the palatine bone. This serves as the roof of our mouth, and we have two of those. So here's one and here's another one. So all in all, we have two. Maxilla, we saw that earlier. So this one you can see here is one and here's two, even though it looks like only one from the very front. Here's that zygomatic bone, lacrimal bone, and another one that we haven't seen yet is the vomer. Also aids in this formation of that nasal cavity. And I believe we've covered all of them. Okay. Oh, also we have one more. Let's see if it's on the next slide. It's the inferior nasal concha. So inferior nasal concha. And then this gives rise to our nasal septum. So it helps break down, divides our nasal cavity in two. Okay. And here's the nasal bone, the bridge of our nose, but not our definitive shape of our nose. That's going to be cartilage. And as you can see here, it's all about opening. All right, so make sure that you know facial bones, once again, all the bones in blue. Not all of them are paired. Only the mandible, everything actually is paired except for the mandible and the vomer, which each only is comprised of one bone. Now let's compare this fetal skull with an adult skull. And if you notice an infant or newborn, you're always going to notice that the baby's head is pretty big, right? And so fetal skull is actually 1/4 the entire body, compared to an adult skull, in which case the skull is 1/8 of the total body size. Now, why is that, and what structures contribute to that? So if we see here is a skull, we notice that we don't have sutures, but rather we have these structures called fontanelles. And what these are is hyaline cartilage, which eventually can turn and convert this into bone. Okay. Now, what is the function of this, and why do we even want this? Well, it allows the skull to be compressed during birth. And also it allows the brain to grow during later pregnancy and infancy. And so for any of you who have a child, a young child, or know someone who is fairly young, you notice that's a soft spot on their head, and that's really what that fontanelle is. Typically, you would probably feel this anterior fontanelle. And then within 24 months, it will be converted to bone after birth. So it's not always going to stay as this soft spot. Oh, and there goes my dog again. Okay, and so within our skull, we also have other structures, and we have something called a sinus, and we have specifically paranasal sinuses. These are located within the bone surrounding the nasal cavity. And they have several functions. So one of the functions that they lighten the skull. They also give resonance and amplify your voice. They also produce mucus, which is why sometimes people have a sinus infection, or if someone has a headache because there's also sinus buildup, this is the reason for that. Now, we have another structure, another bone here, which isn't technically part of the skull, but it's closely related to the mandible and the temporal bones. And this is a hyoid bone, and it's the only bone that does not articulate with any other bone. Oops. Meaning it doesn't actually touch any other bone. And so what is the purpose of this bone? It actually aids in swallowing and in speech. Because it serves as a movable base for the tongue. Hyoid. Okay, now we're going to move on to the axial skeleton, looking at the vertebral column, and each of these vertebrae is given a name according to its location. And there are several locations we're going to look at, so remember your regional terminology from chapter 1, I believe. So cervical deals with the neck, and so our first region is going to be the cervical vertebrae. Thoracic, chest area, this is going to be the thoracic vertebrae. Then we have the lumbar, lower back, so lumbar is going to be the next vertebrae. Then sacral is the next area, and then finally we have coccyx at the very end. And so here we have 26 bones found all in all in the vertebral column, or the spine. And so we have 24 single vertebral bones separated by what type of cartilage? Good. Fibrocartilage. Good review. Okay. And so what are these 24 single vertebral bones? First we have 7 cervical. This is the neck. We have 12 thoracic. So that's the thoracic region. Then we have 5 lumbar. This is the lower back. So posterior of your thoracic cavity region. And this is a pretty cool and neat trick, because I would always get confused with how many vertebra do you have per different region. And I just heard this the other day, and so I want you to think about how with the different times of that you would eat a meal. So you wake up at 7 to have breakfast. At 12 you have your lunch, and then at 5 you have your supper. And then we have, so that gives rise to your 24 single vertebral bones. We also have 1 sacrum bone, and we have 1 coccyx bone, which we also call the tailbone. Okay, and so Not only do you have your breakfast, your lunch, your dinner, you also have one midnight snack, and that's going to give rise to your one sacrum. And I guess you have a midnight morning snack, another one for the one coccyx. Okay, so that's one way you can remember all of these. Now, what's interesting about the sacrum over here, it's actually a formation of 5 fused vertebrae. And this coccyx is also a formation of 4 fused vertebrae, but this is what we call the tailbone because it's actually considered what's a vestigial trait, meaning that our ancestors, once again, had this as a tail. It was a long tail, but vestigial traits are traits that we don't have or have a purpose for anymore. And so over time, what happens? We don't need a tail anymore, and this eventually starts receding, and all we have left is this tailbone. Now, some people can still be born with this tail, and so here we have an example, an extension of this tailbone. Here it's composed of adipose tissue, connective tissue, central bundles of muscle, blood vessels. Sometimes it can be an extension, but sometimes it won't have any bones in it. So it's just an extension of tissue. However, I will upload a YouTube video which I showed to the class of someone who does have a tail and is able to move it. So most of the time you can't move it, you just have it excised, but this person is able to move it. Pretty crazy and nasty, huh? Okay. Now let's look at curvatures of our spines. And so if in an adult spine, what we have is this concave curvature of our cervical and our lumbar regions of our vertebral column. And we have this convex curvature of our thoracic, sacral, and coccyx regions. Now, we have these other regions, we have the other curvatures we call primary and secondary, and these really correspond to these different types of curvatures that we already saw. Now, primary curvature, this deals with the spinal curvatures of both the thoracic and sacral regions. This primary curvature is the initial curvature we have at birth. And so at birth, our entire spine is this nice C shape, and this is that primary curvature. However, over time, what happens? Well, the baby is going to start raising his head, and raising the head is going to develop the cervical curvature. That's why we develop this concave structure. And then eventually, when the baby learns how to walk, that's how we develop this lumbar curvature. So because these are curvatures that develop as that baby develops, these are considered secondary curvatures. So spinal curvatures of the cervical and lumbar regions. And once again, these develop after birth. And this is what we see as an S shape in adults. So here's that S shape that we see. And so this is at birth. That's that C shape in newborns. Okay, just want to make sure I don't miss anything. Now let's look at a typical vertebra. And so we'll notice that it's composed of several things. So even though the structures of the cervical, lumbar, thoracic, and sacral coccyx regions are all different, they have this general structure here. So we have a body, we have a vertebral arch, and this is broken down to our pedicle and our lamina. We have our vertebral foramen. So this is our vertebral foramen being a hole. Transverse, remember transverse means like side or horizontal. So these are the horizontal lateral processes. Spinous is the most posterior one. So that nice long one that you can feel. If every time you feel your vertebra, that's the one that you feel. And then we have superior and inferior articular processes, and these are the regions, these extensions are the processes that hold the facets in which these vertebrae can stack upon each other. Now, the very first two are have different terminology for the cervical region, and it's the atlas and the axis. So C1 is the atlas, and C2 is the axis. And so this was going to articulate or be in contact with the condyle, so occipital condyle, meaning that connection at the very base of our occipital bone. And C2 is going to come into contact with our axis. And so these two go hand in hand in being able to move our head from side to side and then up and down. Now, these are the only two that I would probably quiz you on, and the rest of the structures and shapes you don't need to necessarily know, because you notice that your spinous process is going to differ between the different regions. However, what you should know are the different regions itself, and also the number of vertebra in each region. Okay, so that's really all I'm going to quiz you on. Now, moving on to the sacrum and the coccyx, also part of our axial skeleton. So sacrum being composed of those 5 fused bones, and here's our coccyx. Sacrum, so let's write that down. So formation, it's formed by the fusion of 5 vertebrae. And the function of this is that it protects our pelvic organs. Which includes our reproductive, urinary, as an examples. The bottom of this will articulate with our lumbar vertebra. So here, lumbar vertebra. And then also the apex, so base, is going to be the widest area. And the apex, meaning this pointed area over here, is going to articulate with the coccyx. So here's a coccyx. Now, our coccyx formation formed from the fusion of 3 to 5 vertebrae. Its function, it doesn't really have a function for us right now, but it is a remnant. Structure of a tail that other vertebrates have. So we don't need it anymore. We know this as a tailbone. Now there are a couple of abnormal spinal curvatures that are congenital, and so this is when a person's spine is curved from side to side. So here's one example. So if you ever remember in elementary school or middle school, they make, during physical education, they'll make you bend over, and they'll kind of look at the curvature of your spine to see whether or not you're developing some of these abnormalities. And so kyphosis, this is a curvature rounding of the back. Scoliosis, this is when the spine is curved towards the side. And then lordosis is this inward curvature of the lumbar area. So kyphosis. And then lordosis, inward curvature of the lumbar. Oh, and we didn't write down scoliosis. So scoliosis is when the spine is curved side to side. I had a couple of friends who had scoliosis, and so I know during high school, one specifically, she left a couple of years to get rods implanted here to realign her spine, and we used to be the shortest girls in our color guard group, and after that happened, she gained another 3 to 4 inches, and so, yeah, I was a little bitter. It's like now I was the shortest in the class. Okay. Now, next part of the exoskeleton we have is the thoracic cage. And so this is a cage that protects major organs, including our heart and our lungs. And so these are consisted of 3 different parts. We have the sternum. Our sternum is composed of our manubrium, the body, and the xiphoid process, so those three different things. We have the ribs, and the ribs, we actually have three different regions of the ribs. We have true ribs, false ribs, and floating ribs. We have 12 in all. So the very first 7 are true ribs because these attach directly to our sternum. False ribs are 8 through 12. And these are considered false ribs because they indirectly attach to the sternum. Because they actually attach to the true ribs, all that cartilage of that true ribs. And then finally we have floating ribs. These are not attached to the sternum at all. Okay, so 3 different areas. And then finally we have the thoracic vertebra. And that's just T1. So that's just part of the thoracic cage. That's all. So for your exam or your quiz, be able to identify what's the difference between true, false, and floating. And then also the different regions that comprise the thoracic cage. Now let's look over the appendicular skeleton. And this is composed of 4 major regions. We have the pectoral or shoulder girdle. This involves the clavicle and the scapula. Next region we have are the upper limbs. This involves the humerus, the ulna, the radius, carpals, metacarpals, and the phalanges. Third region we have are the pectoral or hip girdle, or is the pectoral or hip girdle. And this is comprised of 2 bones, our coxal or pelvic or hip bone, so different terms for that. And then finally we have the lower limbs, and these comprise the femur, patella, which is this bone over here, and the patella, I want to make a note of this. This is considered a sesamoid bone because it's a special type of bone. Anytime it's a sesamoid bone, that's when the bone is embedded in a tendon. And then we have the tibia, which looks like the letter T over here. It's a larger bone. And then we have the fibula on the side. Tarsals, metatarsals, and phalanges, these are the bones that comprise the foot. Tarsals, these are going to be the short bones, like your ankles, or the small bones around your ankle. Metatarsals, that's the middle part, and then phalanges are the ones that you can wiggle, your toes. Now let's look at the pectoral girdle, and this is composed of 2 bones. We have the clavicle, and we have the scapula. Clavicle, we also know this as the collarbone. Articulations medially. The clavicle articulates with the sternum. And then laterally, the clavicle articulates with the scapula. Second region, scapula. Scapula, we also know this as our shoulder blade. Articulations for this, we articulate with the clavicle. And this joint that they form, this is called, or the region is called the acromioclavicular joint. And what else do we articulate? We also articulate with the head of the humerus. Okay. Now this region of the scapula where this articulates with, this is called the glenoid fossa. Okay, so you're now probably thinking, oh my gosh, do I need to know all these regions? Well, for your exam number 2, what the exam's going to look like is you'll see a model, anatomical model, position model of the skeleton, and you do need to identify right versus left. And remember, right and left is always the patient's or model's right and left, not yours. And so here as an example, this is going to be, for your exam, you'll probably be identifying, fill in the blank. You're going to write down right clavicle, so spelling will count. And then if I ask you, so you need to know spelling, identification, okay, and then articulations. So because these are bones, you're going to have usually 2 areas where it's going to articulate or come into close contact with another bone. Okay, and so you do not need to know bone markings. And I know in your textbook there are other pictures of the clavicle and the scapula. It'll say like sternal end, acromial end, superior angle, lateral border, and so on and so forth. But you do not need to know those anatomies and those different terms. Now let's look at the bones of the upper limbs. We have here the humerus, which we just saw in that last slide. And looking at the articulations for this, proximally we're going to articulate with the scapula, that glenoid fossa, and then distally we're going to articulate with both our ulna and our radius. So it's different with where they articulate. The trochlea here, trochlea is going to actually articulate with the ulna. Oops. Trochlea of the humerus. And what we don't see here at the back of this region, we kind of know it as our elbow joint, or what we know as our elbow. The other opposite side of this, we have the capitulum of the humerus, which articulates with the radius. And both of these comprise that elbow joint that we know. All right, other articulations, looking at now the forearm. Over here, 2 bones, the radius and the ulna. Radius. This is going to articulate with the humerus. And it also articulates proximally, so this is proximal, with our ulna. Distally, our radius is going to articulate with the carpals of the hand. And we have the ulna. Ulna articulates proximally with the humerus. And then distally, also with our carpals. And the way I always remember which one is the radius and the ulna is if you put your hand in anatomical position, radius is going to have the farthest radius from the center of the body. So here's the center of your body, going outwards, longest distance. So that's how I know the radius. Okay, looking now at our hand. So our hand is broken down to 3 different regions. We have the carpals, which we know as our wrist, metacarpals, and then we have the phalanges. And so here, carpals, these are distinguished, these are considered short bones. Phalanges and metacarpals, these are longer than they are wide, and so these are both types of long bones. Okay, so for our carpals, these are our wrists again, our wrist bones, and there are 8 bones arranged in 2 rows of 4 bones in each hand. So there's 1 row, and then here's the second row. Per hand. Metacarpals is comprised of bones that give rise to our palm of our hand. Oops. And we have 5, right? Because you have 5 fingers, so we have 5 per hand. And then finally we have phalanges, which we know as our fingers. And of course we also have 5 per hand. And so these are the ones that we can actually wiggle. Now you're going to notice here within our hands and our toes, we're going to see a lot of similar terminology. Carpals, so instead of carpals in our feet, we're going to call them tarsals. And then in our feet, we're going to call this middle region metatarsals. And phalanges, these are consistent. So our fingers, both the fingers and the toes that wiggle, are phalanges. Now, bones of the pelvic girdle. This is formed by 2 coxal bones, which we call ossa coxae. And these are the total, what's the function of this? Well, the total weight of our upper body rests on our pelvis. So it's able to carry the total weight of our upper body. Also, it serves as a protective function. And so, once again, we can protect our organs that are important for our urinary system, parts of our large intestines, also down here, and also our reproductive organs. So it protects reproductive, urinary, and digestive organs. And if you notice, it does look like our hip bone is only comprised of 1 bone, but in actuality it's comprised, each of these single bones is comprised of 3 sub-bones. And how they come together is by this cartilaginous joint, and this is called a pubic symphysis. And this allows for the stretching and movement of your bones, so you can widen out our hip bone or our pelvic bone because of this right over here. Now, what are these 3 bones that comprise each of our coxal bones? We have the ilium, we have the ischium, and we have the pubis. So 3 bones. And once again, I know there's lots of terminology for all these bone markings, but you do not need to know all these bone markings for your exam, just the major bones itself. Now, there are some differences between males and females in terms of the formation of this pelvis bone. And thinking about childbirth, of course, females need to be able to bear the child, and that being the case, we can see a couple of differences. And so if we look at the ilia, so here's the ilia, this is going to flare more laterally in the females compared to males. Oops. I can spell ilia. Flare more laterally. Also, if you look at the pelvis itself, it's much shallower and thinner compared to males. And the bones are lighter and thinner. And you can see here, men's much more narrow. Also, the ischial spines are shorter and farther apart, and that being the case allows this outlet to be much larger. Okay, so here we have this ischial spines are shorter and farther apart. Therefore, the outlet is larger. And then finally, a female pubic arch is more round because of the angle of the pubic arch is greater. Okay, so here, much rounder, and that's because this angle is much larger compared to this arc over here. So it's lower than or less than 90, and this one is more than 90 degrees. Of the pubic arc is greater. Oops. It's common over here. Than 90 degrees. Now, what's also interesting, so when a student wants to ask me for that his son was so curious of why is it that women always shake their hips whenever they walk? And what's interesting, well, clearly we know why, right? So our hips, women's hips, are much wider compared to males, giving the appearance of them shaking their booty as they walk. But what's also interesting, we just found an article that was saying that when a female is around her, prior to having her menstrual flow or menstrual period, she actually shakes her hip more, and that's just a way to attract men. And it's just kind of developed from a long time ago, where it's the appearance of now they're getting closer to childbirth, and so they want to attract the opposite sex. And so that's one way. Also, if you know a female is approaching or nearing their menstrual flow, is because if they have a wider gaze, if they shake their hips more, that means that they're kind of ready to procreate. Interesting fact. Okay, now looking at bones of the lower limbs, here we have, starting off with our femur. Femur, this head of the femur is going to articulate with our pelvic bone. So proximal end, articulates with the hip bone. And then distal end, we're going to articulate with the tibia of the lower leg. Now this is interesting because we're not articulating at all with the fibula, only the tibia. Also the femur, interesting, okay, so we know this has a thigh bone, but it's actually the heaviest and strongest bone in the entire body. And imagine all that weight that we have to support on the femur. Okay, oops, so here's the distal proximal. We wrote that down there. Okay. Bones of the lower limb. We have the tibia. We also know this as our shin bone. And remember I said it's the one that looks like the letter T, so that's how I know tibia. And this one also, if you don't remember, looks like a letter T. It's also the larger, more medially oriented bone. Okay, then we have the fibula. This one is a thin and stick-like appearance bone. It's a bone that appears thin and stick-like. and it's lateral to the tibia, so lateral meaning more outwards. And it has no role in forming the knee joint. Okay, looking at articulations. Okay, articulations distally, both of these are going to articulate with our carpals. I'm sorry, our tarsals. Okay. Now the last region, the bones of our feet. So each of the foot is comprised of three major regions. We have the tarsals, metatarsals, and then the phalanges. And so tarsals, there are 7 tarsals that we have all in all. 2 largest we have are the calcaneus and we have the talus. Okay, so these are the 2 that you should know that are part of the tarsals. So tarsals, we have 7 in all. And once again, these are short bones. 2 largest, calcaneus and talus. And then we have 5 metatarsals over here, comprising the soles of the foot. And then finally phalanges. 14 all in all, and these give rise to our toes. Okay? And once again, don't need to know distal, proximal, or middle, phalange, or these other bones down here. Right. Now, since we've went over the bones, let's look at the different ways that these bones come together. And so articulations, once again, these are when the bones come into contact with each other, or if there's 2 or more bones that come into contact. And these areas are where we can have mobility between bones. So contact between 2 or more bones. And this allows for mobility. And because our majority of the bones that we looked at allows for mobility, there are 2 ways we can classify these joints. We can classify them functionally by way they move, whether they move a lot or very little. So if you think about our skull, we had our bones coming together, but there's actually no movement at all compared to something like our hip bone. There's lots of movement over there. And so we can classify it functionally based on the allowed amount of movement that can occur. And then structurally, this looks at what type of tissue comprises the connection between the 2 different joints. So is it fibrous, cartilaginous, or is it a synovial joint? So the first way we're going to look at are the functional classifications. And the first one is a synarthrosis, and these are immovable joints. So functional, once again, being the amount of movement. So these are immovable. And these ones cannot move at all. These are the sutures that we had within our skull. Amphioarthrosis, these are slightly movable joints. And this, as an example, would be our axial skeleton. So here our vertebral column, we have some of that motion, that mobility, but of course these cannot give us that nice 180 degrees or 360 degree rotation. Here we have slight movement also of our rib cage to allow for expansion and relaxation and as we breathe, but of course we cannot move these completely. And then finally we have diarthrosis, which are freely movable joints. Oops. What happened here? freely movable. And we can find these predominantly in our limbs. And so anywhere we remember, like the proximal distal points of origin, so your arms, your hip bones, hip sockets, those are great examples of diarthrosis joints. So lots of movement. Now looking structurally, how do we classify these joints? Well, we can classify them if they are composed of a fibrous joint. These are generally immovable, fibrous tissue, and so we see these in sutures. And we also see this in the distal end of the tibia and fibula. Okay, and so we can really combine both of this. We can classify sutures both as synarthrosis because they're immovable, and also fibrous because they are composed of this fibrous tissue. So two different things. Looking at this, our vertebra, we have cartilaginous joints, and majority of these are going to be slightly movable joints. An example is the pubic symphysis. And intervertebral joints. And so because of this cartilaginous joints, they're composed of cartilage. And like our vertebral column, we have fibrocartilage between each of our vertebrae. Okay. So once again, this one can be classified both as amphiarthrosis, if we're talking about functional classification, but also a cartilaginous. Now we have the last type of structural classification is a synovial joint, and this one allows for freely movable joints, and the articulating bones are separated by a joint cavity, so that's key. And what we have within this joint cavity, if you remember that connective membrane that we have, the membrane composed of only connective tissue, is the synovial membrane, and between that we have synovial fluid. Helping to prevent friction and also absorb that shock. And because there are lots of freely movable joints we have within our body, we're going to cover the different categories of synovial joints and the different types of joints that are synovial in the next few slides. So synovial joint, let's go over this really quick. A couple structures associated with a synovial joint. We have a bursa. This is a flattened fibrous sac. And the function of this is that here's this bursa. It's always going to line the synovial membranes, and it's filled with synovial fluid. So it's not actually part of the joint, so it's not the bone to the bone at all, but it does help reduce the friction between adjacent structures during end of the joint activity. So it helps absorb and break that, absorb shock and prevent that friction. And so functions, it lines, filled with synovial fluid to help reduce friction between adjacent structures during joint activity. But it's not actually part of the joint. Okay, so joint, once again, is the bone-to-bone region. Now, tendon sheets, these are elongated bursas that wrap around the tendons. And tendons, once again, these are going to connect muscles towards your bones, and this also helps prevent any friction, and especially rubbing against our bones as we contract and move our muscles. Now looking at these different types of joints, we can have the first one being a hinge joint. This is characteristic of having a cylindrical end of one bone. Here's a cylindrical end of one bone fitting into a trough shape surface of another bone. Okay, so here is one example, the humerus and our ulna. Here is that cylindrical bone fitting into this trough shape over here. And so it kind of opens like a door. As a door opens and closes, only can open so far. So it allows for angular movement in one plane or one hinge. And once again, it's characteristic by one bone having a cylindrical end fitting into a second bone with a trough-shaped surface. Okay, so number 1, number 2. Pivot joint. This is when we have a cylindrical end of one bone fitting into a trough-shaped surface of another bone. So it kind of seems like the other one. So here's an example, ulnus and radius. Remember, radius doesn't directly articulate here with our humerus, but it does articulate with the ulna, and it does it in this way. And so I want you to put your hand out in anatomical position, and then put your hand then facing superiorly, then face it back anatomically. So facing it superior, and then anterior, superior, and anterior. And you notice your radius is the only bone that's actually moving, and that's because it's moving along this pivot joint over here. And so this allows for angular movement also in one plane or one hinge. So it's not going to go all the way around, just in one plane or hinge. So we also have the same thing, cylindrical. So bone number 1 is cylindrical. And one bone fits into trough shaped surface of another bone. Okay. It allows for angular movements in one plane. The next type of joint we have is the condylar joint. This is characteristic of one bone being egg-shaped and the other side having an oval concave surface. And so here's an example. This is the distal end of the metacarpal. And here's the proximal end of the phalange. Phalange is going to have this concave shape, and this is that egg shape corresponding to this region right here. And so what this allows is movement from side to side, back and forth, but you don't have any rotation around an axis. So I want you to get your finger, point your finger front, point it towards the back, side and side, and you can move your finger around and around, and that's this condylar joint. So one surface is egg-shaped, and that fits into another surface that is an oval concave. Movement allows bones to go from side to side and back and forth, but no rotation around an axis. This next joint is a saddle joint, and this is characterized by two surfaces each having both convex and concave sides. And so here is this concave, convex, here's the concave and the convex. And so really this is just like the last joint we saw, the condylar joint. It's just that the structure of this is going to be one spherical instead of, concave and convex instead of having it being egg-shaped. And both of these will allow the bones to move side to side and back and forth once again, but there's no rotation around an axis. And so let's see, characteristics. Both bones have concave and convex sides. Movement, side to side, back and forth, but no rotation around an axis. And an example of this is the thumb. And so this is the distal end of the carpal, and this is the proximal end of the first metacarpal. And so I want you to get your thumb, give a good thumbs up really quick, push it forward, push it back, side and side, and there you go. The last joint that we have is the ball and socket joint, and this is characteristic of one bone having a spherical head, and the other one that has a region for the spherical head to fit into. And this really allows for free open movement in all axes, including free rotation. Okay, so characteristics, one bone has a spherical head that fits into a round socket of another. The movement is in all axes, including rotation. And so we see this ball and socket of our arm or our shoulder. You also see this in our hip joint. Now the last thing we're going to cover is the inflammatory conditions that are associated with different joints. And so we saw the bursa being that sac-like structure that helps prevent and assist in the joint region, but it's not technically part of the joint. And so bursitis, anytime you see itis, this means inflammation. And so this is inflammation of the bursa that is caused typically by a blow or from friction. Caused by a blow or friction, so blow to the bursa. Tendinitis is this inflammation of that tendon sheath. And then arthritis, this is an inflammatory or degenerative disease of the joints. And really there are over 100 different types. It is considered the most widened crippling disease in the United States. And so we're going to look at one example of this. So inflammatory or degenerative disease of the joints. And there are some symptoms that are associated with this. You typically feel pain and stiffness, and also swelling of the joints. The one form of arthritis we are going to cover is rheumatoid arthritis, and this is an autoimmune disease in which the immune system starts attacking the joints. Now, what actually causes this, we don't know. However, what happens is that here we have at these joints, these are all synovial joints, and that being the case, we continuously replace this with synovial fluid. Over time, what happens? Well, the synovial fluid can carry antibodies, which start to begin to attack proteins that can be found within the synovial cavity space that the body once did not attack before. And because of that, what happens? Well, with inflammation, you have increased flow of white blood cells, of areas to attack any of those things that are now considered pathogens. And because of this, because we have increased flow of these different components to this joint area, we start to create deformities. And so if you can just imagine here, the synovial fluid starts getting filled up with fluid, As this increases, you're pushing the bones towards the sides. And this is an x-ray of someone who has severe rheumatoid arthritis. Okay, so let's write this down. So it's an autoimmune disease in which the immune system attacks the joints. Treatment options, they have anti-inflammatory treatments, and so medication for that. And I remember one time one student said, well, why don't you just cut out the synovial membranes, which is really our synovial membranes giving that connective tissues that give rise to all the synovial fluid. Well, really we can't do that, right? Because the synovial membranes are going to continue to regenerate all that synovial fluid. However, there is some research now trying to create stem cells. So remember the whole idea of stem cells. Stem cells can give rise to any cell population, and that's what's important. So potential for stem cell therapy, getting new stem cells in here, treatment in order to replenish and create a new type of connective tissue membrane to regenerate synovial fluid, in which case won't produce any of those antibodies that the body will then use to attack anything that's considered foreign. Now, also characteristic leading to deformities. Okay. All right, and that's it. So this is all we're concluding with for Chapter 5. I will see you in Chapter 6.